So this is a guide for clinicians providing mental health services to clients that are deaf and hard of hearing. I'm Leisha Campbell. I'm a psychotherapist in the greater Houston area. I have over 16 years of counseling experience and working with deaf and hard of hearing individuals. So this presentation will have 3 parts. We strongly encourage you to view all parts 1, 2, and 3 so that you get a better understanding of all of the facts, barriers, and factors that will influence accessing mental health services and supports and things that you can provide to support deaf and hard of hearing clients better being able to access mental health services. So the next section that we're going to talk about are some elements for a mental health clinician to consider and some suggested strategies that you can implement as well. So you should be very observant of the interactions when a client first walks in. Did they walk in by themselves? If they walked in with family members or a person that they have a significant relationship, were their interactions friendly? Did there seem to be tension or stress? Does the client appear to feel safe with the people that they came with? The language level of the client. So their reading comprehension and writing skills are also very important. Functional communication skills, ask them general questions. Can they tell you what they do every day? Do they know their schedule, their routine, what school they go to, where they work, the responsibilities of their job, things they like to do in their free times, things that they don't like to do. Considering, do they have an intact language? Previously, we talked about having an L1 or a dominant language, whether that is spoken and they have intelligible speech skills or an intact language in the form of American Sign Language. That will also help you assess how to adjust your therapeutic mode and the therapies that you will provide. The other thing is to consider and know is that language deprivation does occur in the deaf and hard of hearing community. What language deprivation means is that the deaf and hard of hearing person, when they were growing up, did not have access to acquire a dominant language and to have exposure to language. That can significantly impact them in many ways. So previously we talked about when children are born from 0 to 5, their brain is ready for language. If there is no language inputted into the brain closes off about age 5 and those connections are not made. So therefore, when the person is growing up, they don't have a lot of knowledge. They may have a lot of behaviors that may seem bizarre or not normal, or different ways of acquiring their needs that may be maladapted. So those are some other things to consider, and there will be some resources posted later if you would like to learn more about language deprivation. Consider and ask about education, life, and work experience of the individual. Where did they go to school? Did they graduate from high school? Did they go to college? Did they obtain a bachelor's degree, a master's degree? The more education a deaf and hard of hearing client person has will kind of let you know their functioning level as far as their life, how independent they are, also their reading comprehension and writing skills as well. Also their work experience. Have they been able to maintain a job, or do they get a job and are often fired from it because maybe they are frustrated or they're angry or they are not sure how to interact in the hearing world without a sign language interpreter, without supports that they maybe had while they were in school. Another thing to consider is past possible trauma or abuse experiences that may not have been reported or processed. Many times in deaf and hard of hearing community, they experience trauma and abuse, and it is not reported appropriately to the Child Protective Services or to the authorities or law enforcement. In addition, the healing process of a trauma may not have also occurred, and so when they are receiving mental health services, those traumas and abuse experience need to be addressed so that they can be able to move on and be successful with what their goals are in their life. A recent study from Rochester Institute of Technology, as recent as 2010, reported that more than 25% of college students deaf and hard of hearing and youth had a post-traumatic or abuse event, and that it was causing them depression or anxiety and post-traumatic stress in their adulthood. So that's just something to keep in mind. There might be some possible past resentments, anger, feelings of discrimination that also the person may not have dealt with. What that may look like is a lot of times when deaf and hard of hearing clients go to get a job, many times they may not get the job. They may be qualified, they may have the degree, meet all the criteria, but because the hearing person that is in charge of hiring may be afraid or not know how to interact with a deaf and hard of hearing person, they may just discount the person and not even give them a chance. After that has occurred several times for an individual, of course, resentment would arise and anger and frustration that they are not able to be provided those same opportunities as another hearing individual. Please be aware that your counseling and therapy techniques may need to be adjusted to match the needs of the client. So, for example, if you are using cognitive behavioral techniques or open-ended questions or things that involve a lot of abstract concepts, you may need to adjust them in order to meet the needs of your client. So here are some suggested strategies that we would recommend you using when you're providing mental health services. First of all, and most importantly, allow and empower the client to choose their focus of treatment. If you have an adult coming in and they have experienced trauma, abuse, frustration, discrimination, oppression, and maybe also they're going through a divorce, allow the client to focus on what the treatment needs to be for that time, because you would have to have a significant number of time to address all those issues. If there's auditory and spoken messages between you and the deaf or hard of hearing client, understand that even though they may have auditory and spoken skills, it will still take them a little additional time to process the information. If you are using American Sign Language or an interpreter, as the clinician, you will need to state the message, allow the interpreter to interpret the message, and then allow the appropriate wait time for the deaf client to respond. Also be aware of English vocabulary and multiple meaning words. So just for example, the word running. So you have running water, you have your nose is running, you have them running down the street. Just be very cognizant that a lot of words in English mean a lot of different things, and as a deaf and hard of hearing client, things may get misunderstood. So if you see that the person is not understanding, check for understanding, go back and explain in a different way by giving an example of what you meant. Also remember, abstract concepts may require additional explanation and expansion. Things like self-talk in the mental health, or using I statements, or things like that, journaling, all those kinds of things we need to provide examples of and be able to explain what they are. Don't just assume the client already knows what they are. So provide examples when you're introducing any new concept, medications, making medication changes, therapeutic techniques, coping strategies, and homework. So when you're asking questions, have a backup or additional similar word to express the message when you're trying to explain a concept. So for example, who's in your family? The person may be able to respond and say, oh yeah, I have my mom, my dad, 3 brothers, 4 sisters, no problem. Or you may get a confused look. So if you get a confused look, a response that does not match the question, or no response at all, have an alternative that says things like, who lives in your house? Or how many brothers or sisters do you have? Did you grow up with your mom and dad? Also, why were you mad? Why were you frustrated? That is an open-ended question. The person may be able to easily answer that question. However, if there's some difficulty, provide examples such as, you were yelling at your coworker, or you threw the book at school, or you got mad at your mom when she told you no, you couldn't go with your friends. What happened first? What happened second? What happened next? What happened after this occurred? Ask them how they feel, and also provide choices and modeling of what those feelings are. Because other than happy, mad, and sad, some of the more complex feelings of frustrated, overwhelmed, excited, or disappointed may not have been explored with the client before. I have a couple of young clients, when they come in, I sign fluently, but they do not. And so it's very hard to communicate or provide them support. A lot of times I have to do drawings or puppets and things like that to help try to figure out why they are mad or why they are shutting down. Most of the time, what that usually looks like at the home for language deprivation is that when I ask the parent how they are communicating with them, they are gesturing, so they just point, or they do everything for them. So as far as dinner, they just point to the table that it's time to eat. So they're not signing as eat. They're not explaining, tonight we're having, chicken for dinner, or we're having spaghetti for dinner, or how do we make the spaghetti? They're not doing any of that. So all the child knows is that I was playing. I don't know what I was playing with. I don't know the names of these toys. I don't know the names of my siblings. And to me, that's the hardest, saddest part. Is when a child does not know the names of their siblings. And when I ask a child, how many brothers or sisters, they may be able to say that. They may say boy or girl, but then I'll say, what's their names? And they can't tell me. There's no sign name established, but they don't know their names. They don't know their ages. And so a lot of times the parent is just doing everything for them. They're just going through their routine. They're eating, they're bathing, they're putting them to bed, but there is no explanation or language or conversation of connection of any sort going on with that parent or child. And so that language deprivation has a serious impact with that child once they grow up, because there's very few things they can do for themselves. They can't be independent. They have a hard time holding down a job, just paying bills, establishing friendships with other people, making emotional connections, and having significant relationships is often very difficult. Additional strategies that you can implement include things like utilization of social modeling and sample scenarios, examples, positive replacement strategies, or behaviors. So you want to give examples of what the desired behavior or coping strategy is. So instead of getting mad and slamming the door, or getting upset, leaving the room, or getting mad and throwing things on the floor, you would give the example of, we would like you to say, hi, I need a 5-minute break. I will be right back, and they go to a safe place. Addition, you can use role play, and you can also use drawings. So some examples of what social modeling looks like: when you were asked, why were you sad? You would ask the question, wait for their response, and then say, remember you were crying at home, work, or school? Give examples. Did someone hit you? Did you get what you want? Did you not get something you want? Did someone leave? Did you miss someone? Give those examples. If you have a history of the client and some of their experiences, you can provide those as some of the examples as well. You can also use drawing of feeling faces to help explain those different feelings, and then allow the client to also add to how they were feeling as well, and implement the role play with those. Also, with deaf and hard of hearing individuals, there can be additional disabilities or additional medical conditions that are also the person may be experiencing. So we have deaf and blind, we have individuals with limited language skills, autism, and situations that you may need to consider and provide additional support. So some alternative ways of communicating other than spoken language or sign language could include things like drawing, role playing, tactile objects, object symbols, doing hands-on activities like games and puzzles or sand play. Using real pictures is also a very good way. You can use real pictures from the internet, real pictures from that person's own phone collection, or media pictures to provide an example of a concept you're trying to relay. And also for younger kids, using books with very vivid pictures, and also using social stories. And lastly, using language experience books, which basically the person has an experience, and then you make a story about the language that goes with that to help them understand what they're feeling and what they're experiencing. Okay, so there was one client where we were just talking about, different fun things to do, things that may make you happy, or things that you can do, or coping strategies you can use when you're having a bad day. So when we're talking about that, so when you feel mad or when you feel sad, I'm like, everybody has coping strategies. Everybody has things that make them feel better. So what are some things that you like to do? And there was no answer. I was like, okay, well, what's fun? Like, what's happy? And so I started providing some options like, okay, do you like to draw? And they were like, oh yeah, I like to draw. I'm like, okay, great. Do you like to go for walks? Do you like to, there's some people that like working in a garden, and they kind of just looked at me and they didn't know what a garden was. And then I was like, okay, how do I describe what a garden is? And I'm like, grass and flowers and there's dirt and, all these. And they're just kind of looking at me and they're like, well, they know what grass is. They know what dirt is. They've seen a flower. But putting that all together to know that that's a garden. Things like a farm, if they've never been there and no one has explain that that is a farm or giving them a visual representation of that, picking strawberries or just things that people do. Another one is going to the zoo. When you ask like what are some fun things they've done with their family, the parents have just told me these wonderful things they've done, that they've gone to the zoo, they've gone to the museum, all these things. But when I'm talking to the deaf and hard of hearing child who does not communicate, not able to communicate with their parents, they don't know what a museum is. They don't realize where they just went 2 days ago was the museum, and that there were the paintings and who those paintings were, or that was the zoo. And there were animals and they enjoyed it, but they didn't know the name of the animals. They didn't know there was a bear, there's a lion, there's a tiger, because that parent wasn't able to say, oh my gosh, look at the elephants, look at the giraffes, things like that. And so that's just another example of the schema. Now, once you explain it to most deaf and hard of hearing individuals, they're like, oh yeah, I know what that is. But sometimes you just have to take that step to really understand and check for understanding that if they give you that confused look like I don't know what that is, just explaining it and relating it, the term you're using, to an experience they have or something they do know or have schema about. The other thing that you need to consider is working with clients with co-occurring diagnoses. This also frequently occurs in the deaf and hard of hearing community. This can happen with substance abuse, with illegal and legal substances, and this may also have to require referral to a psychiatric service or hospitalization, or inpatient and outpatient substance abuse treatment. Some different resources are listed, such as the Substance Abuse Screener in American Sign Language is one tool that you can use that was developed with Dr. Derek Duffman, and there's resources listed for you to access and do more research about that as well. And that concludes this section of elements to consider and strategies for mental health clinicians.